Hi everybody, so I'm Alison and I'm the Thrombosis Nurse who's based at Wellington Hospital. I'm going to talk a little bit today more about processes and with it being International Nurses Day coming up, talking about how nurses can actually lead stuff and make big changes. So I started working about 10 years ago at the Anticoag service as it was then known. We had about 1,500 patients that we used to sit on the phone and say, this is your INR, take this, retest then. And that was literally what we did all day. We then clicked on to hang on, we're the only place in New Zealand that's actually doing this, and maybe it's not such a good idea. So we went through putting together a big plan for transferring all the patients back to primary care. The GPs threw their hands up in absolute panic and said, we haven't done this for years, help, help. So we put together a big education package. I think we did one here actually, one in Kapiti and one out at Pororua. We also did education packs with DVDs and the flip chart and all that kind of stuff. So it was all very, very well done with the GPs. The patients also raised their hands in panic and said, oh my goodness, big change, didn't like it. So we did it over about a 3-year period and it was literally a couple of patients at a time to each practice. There was lots of phone calls, lots of support there for the GPs and the patients to reassure them that it was okay, we were still here if need be. I think I've now got approximately 50 patients left that I look after, and they're the complex patients, either thrombophilias. I've got a couple of mitral valve replacements who've also had intracranial hemorrhage, so need that little bit more of a gentle balancing act. So those are the kinds of patients that I look after now. So with me transferring all these patients back, it left quite a lot of time on my hands to fill. And what we were doing was, we actually noticed when we were going around the hospital talking to people that each department was doing their own little thing with their own surgical patients. Some departments were actually just stopping all anticoagulation. Some departments were actually bridging everybody. And there were a few adverse effects that were coming out of this. Simple procedures such as cataracts. A couple of patients actually stroked because they weren't correctly managed. So we decided, myself and Prof Carter, when he was with us, to actually write some bridging guidelines. So it was providing a bit of an umbrella guidance for the hospital. So that was quite a huge chunk of time that took. I also do a lot of general advice over the phone to GPs, practice nurses, dentists, anaesthetists, house surgeons, and people within the hospital. I also go and see new patients in the emergency department with newly diagnosed PEs and DVTs. So I provide education to the patient, decide what's the right anticoagulant for them, educate them on that anticoagulant, teach them how to do their own Clexane, and get all the special authority and scripts and all that kind of stuff done. I then see them in approximately 6 weeks afterwards in VTE clinic, where we just make sure everything's going well for them, any questions, things that they can do in the future to stop it happening again. So if they were going for surgery, put your hand up, I've had a clot, don't let me do it again. And travel advice, all that kind of stuff. And education as well to staff within the hospital and outside of the hospital as well. I've highlighted there the bridging plans. That's now a big chunk of my job. I can get up to 60 referrals a month, going from the nice, simple, easy ones up to the real complex stuff. So with the bridging plans, leading on quite nicely from where Rachael was talking, each patient must be assessed for the bleeding and the clotting risk. And actually, does it actually need to be stopped at all, like we've talked about a lot today? If it's deemed that yes, it should be stopped, then they need an anticoag bridging plan. So this is just a quick slide on sort of my referrals as the process have gone on. Obviously August was a bad month last year. So that's just showing what's come through. Specialties within the hospital that use me are all listed here. There's only one department in the hospital that doesn't use me now, and that's because they've got some processes to sort out themselves, and they shall remain nameless. Majority of my work, urology, orthopaedics, and gastro. So this is the risk stratification table that I use to deem whether the patient is low, moderate or high risk, and this is out of the CHEST guidelines, the ACCP, the 9th edition that we've talked about today. It's split into 3 sections, so heart valves, AF and VTE. You've always got to have those patients that don't fit into those boxes, and that's when I tend to lean on these people over here to give me a little bit of guidance. So anybody with an MVR is always going to need bridging. AVRs are always a little bit hit and miss if they've got an AVR with no other risk factors, so no AF, no diabetes, going down your CHAD score list really. They don't actually need bridging, they come into the low risk. Always makes me a little bit twitchy, and I always go and get those ones checked out with cardiology as well. AF we've talked about quite a lot today. There was a patient a study a few years ago that's saying to bridge or not to bridge with the AF patients. And it was basically saying that they do not need bridging. I felt a little bit uncomfortable with this, and we had a meeting between haematology and neurology, and we came up with a safety net that is a patient who's in AF but they've had a TIA or a CVA, then we will choose to bridge that patient, usually just with a 40 milligram dose. With your VTE patients, you've just got your high-risk thrombophilias, recent VTEs, and then going down there with the time scale. So the process that we use at Wellington is the surgical coordinators, when they're doing their triaging, they identify that a patient is on anticoagulants. They then email me, I then put the plan together. It's on a template on the hospital service, so everybody has got access to that and everybody can see the plan. So once I've put the plan together, I will then contact normally the house surgeon or the registrar of the surgical team that the patient is coming under, go through the plan with those, and they finalise it on the system. So basically it's a surgical team saying, yes, I agree with what you've said. I will then go and see the patient in pre-assessment, go through the plan with them step by step, teach them to do their own Clexane if need be, and provide them with a pack, prescription, special authority number, nice little sharps container, watch a DVD with them, have a little practice on a practice belly to make sure that they're happy to do their own injections. That also gets transpired then to the GP, so they know what we're doing as well. I'll then also call the GP and say, hey, listen, I'm going to steal your patient for a wee while just while we get them through this bridging process. Post-surgery, I normally go and see the patient on the ward and make sure that they're all good. And once they go home, I organise the INRs and I will look after them until their INRs are therapeutic. The Clexane can be stopped and I'll then transfer them back to the GP care. Patients also given a form that looks a little bit like this. So it tells them when exactly to stop their warfarin. So have your last dose today. I missed 2 doses of warfarin. Test the INR and make sure that they are subtherapeutic before I advise them to start the Clexane. When we first started, we just missed a couple of doses and started the Clexane, and we actually had a couple of patients that were still therapeutic, they were still up in the 3s, and we'd started Clexane, which obviously isn't a good plan. We also put a copy of this into the patient's notes, so this is completed on discharge, so the patient knows exactly what to do. I use MedTech. I don't know whether you guys use MedTech as well. And I will do all these points of contact with the patient. So I give myself like little tasks, as you know. So I'll go and see them at the pre-assessment appointment. I do a phone call reminder that it is their last dose of warfarin. Chase the INR on that day, advise them to start the Clexane. Phone call to the patient to remind them that it's their last dose of Clexane. Check that they've been admitted on the day when they're supposed to be, and then check when they've been discharged. And then it's the follow-up phone calls and arranging INRs afterwards, and then manage them until they're nice and therapeutic afterwards. That's my processes. I think it's something that if you've got people who are going through surgery, it's something that you could probably use sort of with the MedTech, just using your little flags to manage the patients through that.